host, Dr. Ritu Santwani, Director, Shyam Well Women Clinic and Pune TestTube Baby Center. I am privileged here to introduce once again Dr. Pai sir. Pai sir doesn't need any introduction. Till now, it is a history in the Pundit show. The last show when I was done with the Pai sir, that was live watched by 5,500 doctors. So big congratulations to you also, sir. So we all
thank you.
Yeah, we all are your followers, sir. So we are very much thankful to you, sir, that you accepted my invitation for coming once again in the show and enlightening all of us.
Thanks.
So, yeah, Weber, can I have the biography of sir, please? Yeah. Dr. Hrishikesh Pai sir. Pai sir is MD, FRCOG, FCPS, FICOG, MSc, USA. Sir is presently Medical Director, Bloom IVF Group, President-elect Foxy 2022-23, Administrator Foxy Manyata Initiative, Director Corporate Affairs, IFFS, International Federation of Fertility Societies, Adjunct Assistant Professor at Eastern Virginia Medical School, USA, Postgraduate Teacher in Gynecology at DNB Examination, India, Visiting Professor in Ops and Gynec, Manipal University, India. Sir's main interest is infertility, endoscopy, IVF, ICSI, egg freezing, and genetics. Sir has so many achievements. The major achievement, sir, is awarded with esteemed fellowship of the Royal College of Obs and Gynec, London, UK. Sir is past Secretary General, Senior Vice President, Deputy Secretary General, Treasurer, Chairman Foxy, past President, ISAR, IH, and MOX. Sir has so many honors, awards, and publications, awarded with 30 plus awards, including the prestigious Lifetime Achievement Award for Outstanding Contribution in Reproductive Health by Indian Society for the Study of Reproduction and Fertilization. So many awards by Foxy, Indian Medical Association, and other reputed organizations. Sir has delivered many orations and invited as faculty across the world, editor of over 16 and more books and written more than 50 chapters. Editor, Indian edition of British Journal of Ops and Gynec. Sir is founder, chairperson of the Indian ASRM. Numerous research publications Sir is having on his credit. Webu, can I have next slide also? Yeah. Sir, a very warm welcome to you here. Sir, after the first show, I invited the sir on the 26th show, and today I am having a 46th show. Sir, I have got a huge number of requests all across the globe. Everyone want to listen to you. So, sir, especially I've got a lot of requests from the Africa and the Arab countries. They all requested me that they want to listen to you, sir, regarding this, how to increase the outcome of the IVF pregnancy. So, but before we will switch on the lecture, sir, I want to, please, you should share with us some tips for the young budding gynecologist.
So, no, I am, can you hear me, Ritu?
Yes, sir.
Thank you very much, all of you, for love and affection. I, feel that the young people, the life is going very fast. Our time we entered medicine, we didn't know what we were doing. We just took medicine. There was some thought of service and all that, but there was no other options that we had at that point in time. And everything went on smoothly. Suddenly, last 5 years I've seen, in fact, last 10 years of my life have been the most rapid. It's like going on a roller coaster. So times are changing so fast. And when I was traveling 10 years back, I had read in one of the magazines, in the Fortune magazine, I think they said that you will have to change your career 3 times.
Okay.
You have to keep on changing yourself. You have to keep on evolving yourself. You can't be static. Once upon a time, you would be static, but now you have to dynamically keep on changing. Of course, with such a kind of dynamics change, there is a lot of stress generation also. So you have to understand that you have to have aspirations. Unless you have aspiration, how can you grow? You must have ambition. But at the same time, you must also enjoy your life in real time. Don't lose the objective. Objective is to achieve, but to at the same time enjoy your life in real time and achieve. And the second, my advice to us is that we doctors, when we were created doctor profession, people looked at us from the service angle.
True.
Means doctors were there for treating the patient. So our primary objective was to give service. Down the road, lot of biotechnology advances came in. So our line started becoming dynamic. It started becoming more scientific. New advances came in. And so what has happened is we have got carried away by that part of our profession. We have two parts. One is the service part and one is the invention part. Change, someone is doing simple vaginal hysterectomy, then someone started doing abdominal hysterectomy, then someone started doing laparoscopic hysterectomy, then they started doing total laparoscopic hysterectomy, then they started doing single port hysterectomy, then they started doing robotic surgery. And just today I was seeing someone is doing teleportation, means you can operate here and operate somewhere in other city through the robotics and through 5G. But so, technology is there in our life, but at the same time, people don't understand that. The consumer, the patient, they look at us that they want service from us. We have changed in our mind. We have become more savvy technologically, but that people don't understand. They only want service from us. So you understand there is some kind of this disparity, and this creates friction. And this creates people are saying, oh, doctors are not, in the original time they used to touch up feet and all that. Now they say, oh, the doctor is he's not service oriented. He is after money. He is after his own thing. So there is a disparity. This disparity should be corrected. We must not allow the patient to feel that we are not service oriented. Patient expects service from us. And that is why there is some amount of unhappiness between us and them. You understand? This is the problem.
Yes.
We are carried away by technology, but they are not bothered about it. They don't care. They want only service from us. We are saying, oh, we are doing such great technology. Why are they not appreciating us? But they think that is obvious. They are expecting it from you. They don't think that it is something great that you are doing.
True.
I feel. This is my opinion. So coming back, my advice to all the young people is that you must be, but if you chat with the patient, you keep on in a mind that service is very important. At the same time, don't go after money. Money will come to you. Don't go after it. See, in my generation, we didn't go after money. Money just came to us. So, and the second thing, you need to be patient. Like suppose you were in kindergarten. How many years it took you to become a doctor? 15, 20 years. So, similarly, in practice, you have to be patient. See what has happened. Everyone is very aggressive. They are on social media here, this, that. Everyone is trying to do it very fast. But if you do it fast, somewhere down the road, you may collapse. So you must do it slowly. Take it easy. Look at the long-term goal.
True.
This is my advice.
Yeah. Sir, as lot of new doctors also join every time. Sir, before I start the session, sir, everyone wants to know that what motivated you to become a doctor? Though I know we all, but some doctors every time newly joined, so everyone is so enthusiastic to know about you.
No, actually, I was very good. I had got 100 out of 100 in my mathematics exam, and during my time, we could take either medicine or engineering, and I was very confused. My father was a doctor, obviously, but at the end I chose medicine. I don't know why I chose it, but I'm happy when I look back. I'm happy. At that point in time, we didn't have many options. So we were less confused than today. Today, there are a lot of options. But I think medicine is overall a great line. It is a service-oriented line. It has biotechnology in it. If you are very savvy and you are having management skill, you can go and have a big chain of hospitals also. So you can do business through it also. But remember, as I told you, you must always keep that in mind that we are service industry. We have to have CSR, corporate social responsibility, all the time. Always be kind to your patients. Do free work for your patients who can't afford it. Because that in our Hindi we say na dua milti hai na wo bahut zyada hai. Paisa, money is not important. So again and again I'm telling you, money is not important. Money will come to you. If you shun the money, you push the money away, money will come to you. You run after money, it will run away from it.
True. So thank you so much, sir. So today, sir is going to discuss with us a very important topic: how to increase the success rate of IVF. Before I will hand over the stage to sir, friends, I want to commit here. Sir is so humble, in spite of being such a busy schedule. Sir every time replies the WhatsApp. If sir is not able to pick up the phone, sir definitely replies. So, sir, I am very much privileged and very much thankful to you that you always accepted my invitation. Over to you, sir. Yeah.
Thank you. I hope a little bit longer talk today. It's on optimizing results. So,
Yeah.
IVF is not only success rate. IVF has got a multiple thing. What are they? One is of course, improving implantation rate, clinical pregnancy rate, and live birth rate. But there are other things also: reducing the complications of hyperstimulation, strengthening the IVF lab practice, reducing multiple pregnancy, overcoming IVF failures, giving birth to genetically and epigenetically normal babies, and making IVF more cost effective without affecting outcome. All these things contribute to the success rate of IVF. So this is the sad live birth rate of 2010. I purposely put this slide because this is from my old presentation where you can see here in fresh embryos of the patient, non-donor oocyte, patient less than 35 years of age, the pregnancy rate, live birth rate is 41%. Okay, that is in 2010. Now, in 2017 data, the live birth rate has gone to 55%. Can you see here? But this is, now we have changed our definition. What is the new definition? SART is the Society of Assisted Reproductive Technology, which is the American Society of nearly 350 IVF centers. Data is there in this. And every year they have a voluntary data collection. So they have defined cumulative live birth rate. This reflects the chance of achieving a live birth after a fresh or frozen transfer within 1 year of cycle initiation. So from one IVF cycle, how many people become pregnant? So you may have from one IVF cycle 10 embryos that you freeze, and you may transfer them in the next one cycle, and the amount of babies that are born, that is the live birth they are calculating, because they want to encourage all of us to transfer single transfer of embryo. So suppose the patient has got three blastoses. Instead of transferring 2 or 3 blastoses at one go, we can transfer one blastocyst first time, another after some time, another after third time. They don't want us to get pressurized in transferring more than one blastocyst, because that will result in multiple pregnancy. So by changing the definition of the live birth, they are giving you time to breathe, so that you can compare your live birth rate and say, okay, I have the same live birth rate. Suppose one of your competitors is putting 2 to 3 blastocysts. It has no relevance now, because the live birth rate, your live birth rate, will be the same as his live birth rate, even if you put one embryo back every time. So now, I wanted to show you that as the age is advancing, less than 35, 55%, 35 to 37, 41%, 38 to 40, 26, 41 to 42, 13, more than 43, 4.4, 12% twinning rate is there. Some people are still putting double transfers and all that, especially in older age group. And the triplet rate is 0.3%. This is the rate which you should aim for in your practice. So how, when you are assessing for female, you do clinical examination, blood test, hormone test. 3D ultrasound is very important, and antral follicle count. 3D ultrasound will diagnose a septum, a polyp, a malformed uterus or a T-shaped uterus, or all these are adenomyosis. Everything can be easily picked up. So you must do at least a 3D. Sometimes a laparohistro may be there. AMH is calculated 2 to 3.5 is the normal range. And if there is a low AMH, remember, AMH less than 1.5, then you must think about various things like Turner syndrome. So you do a karyotyping. Fragile X syndrome is sometimes low AMH in 5% of Fragile X. They manifest as low AMH patient. Thyroid profile should be done to rule out thyroiditis. Sometimes you need to do laparohistoscopy to rule out tuberculosis, especially. A TB PCR may be done, and also to rule out endometriosis. You assess the male as well. Standard semen analysis is, of course, important. Clinical examination is important to palpate the varicocele. That is very important. And hormone tests, color Doppler may be done. Karyotype HY deletion normally in patients of azoospermia. And nowadays we also do sperm DNA fragmentation tests. If suppose the fragmentation is more than 30%, we know that there is a problem with the male and you can do antioxidant. So hormonal modifications such as obesity, weight loss, diet, exercise, metformin, bariatric surgery, if the BMI is more than 35, especially more than 40, a bariatric surgery may be done. So all my patients with obesity, I always like to reduce their weight. Then hyperprolactinemia, more than 23 MIU per ml, hypothyroidism, TSH value of 2.5, or you can sometimes do even thyroid antibodies, and these are important to see whether there is any problem, and if there is a problem, you can give them bromocriptine or cabergoline. You can give them thyroxine to correct the thyroid. And if there is a thyroid antibody, you can give them steroids as well. Pre-ART therapy, if there is a PCOD patient, normally a PCOD LH by FSH ratio will be more than 2:1. There will be typical necklace sign pattern on ultrasound, and AMH will be more than 3.4. Then in those patients, you need to improve the BMI, by reducing the weight, by giving them metformin, etc. If there's a hydrosulfing, accumulation, you need to remove or disconnect the hydrosulfing. If there's an endometriosis, you should not touch it nowadays, unless if the patient is symptomatic or the endometrium is too large and you think that it will come in the way of the oocyte retrieval. In those patients only, you can put in a laparoscope and do conservative surgery, not remove the, remove partial capsule only. Don't be very aggressive, because that can decrease the ovarian reserve. And you must give a GnRH agonist suppression 2 to 6 months prior to the ovum pickup before you do the transfer. In many of us cases, we do the pickup, we freeze the embryos and then do the transfer at a later date. If there is a fibroid, we remove it. If there is a submucous fibroid, or if it is distorting the cavity, and if there is a large intramural fibroid of more than 4 to 5 centimeters, many people, even if it is not distorting the cavity, people tend to remove it. In fact, in my case, I normally would not remove it. First transfer I will do, because we may have medico-legal issues. Someone will say, why did you remove the fibroid? There is no meta-analysis saying it. So first transfer you can do, even if suppose there is a fibroid of 5 centimeters, it is intramural, but it is not disturbing the cavity. First transfer you can do on your own without touching the fibroid, and maybe the fibroid will not interfere and will get a pregnancy. But if you don't get a pregnancy in the first transfer, surely you can remove the fibroid before you do the second transfer. Adenomyosis, again like fibroid, if it is large, I've seen in African patients, huge adenomyosis is there. So in those patients, we now do adenomyomectomy. We can even do reduction. So first we'll do the ovum pickup, remove the eggs, make the embryos, freeze them. After that, suppose the adenomyosis is less than 12 weeks size, you can give GnRH agonist 2 or 3 shots of goserelin and reduce the size of the uterus, and then do the transfer of the embryos. Or if the uterus is too large, even in those patients, first transfer can be done. And if that first transfer fails to patient become pregnant, then prior to the second transfer, you can do a reductive surgery by laparoscopy. Sometimes the adenomyosis is so large that it comes in the way of the oocyte retrieval, in which case you will have to first go in and redo the reduction and then do the transfer. What about hysteroscopy? So I have been doing hysteroscopy a lot when I started my practice, and I'm really getting good results. But nowadays, in recent times, a lot of people are reluctant to do hysteroscopy. So now what I do a 3D ultrasound. If there is nothing, I will say, okay, we don't do hysteroscopy. I'll do the IVF. I'll do the freezing of the embryo. First transfer I may do on just like that, and many people, they achieve pregnancy. But if they don't achieve pregnancy in the first transfer, then before the second transfer, I do a hysteroscopy. So only if the 3D ultrasound shows a polyp and all, I'll do it in the first transfer itself. Or if there is a history of thin endometrium, or if there's a patient who comes to me with 2 recurrent IVF failures, then in those patients, I'll freeze the embryo, then do the hysteroscopy, then do the transfer. So there is this Cochrane review of Kamath et al., which he has shown that there is a low evidence. But I'm telling you about my practice. See, please understand that there is a lot of evidence, but I'm not telling you about. I'm telling you a little bit about evidence-based medicine, but I'm also telling you about what I do in my practice. Nutritional status is very important. Mediterranean diet, lean meat, fish, fruits, vegetables, olive oil, high protein diet, low glycemic index diet, low in trans fat, high in omega-3 fatty acid, iron, calcium, zinc, selenium, vitamin B complex, B12, vitamin D, folic acid, coenzyme Q, lycopene, arginine, hypoxanthine for the male. This is important because we should not rush in. The nutritional status is very important. Infection, look for chlamydia infection. If there's a history of PID, treat it with doxycycline course. You look for genital tuberculosis or look for chronic endometritis. There are a lot of tests for chronic endometritis, especially if patient is a recurrent IVF failure. You can do a endometrial biopsy and do histopathology, culture, staining, PCR or NGS. And nowadays you can take the biopsy and do next-gen sequencing analysis of the endometrium. And there are two tests that are available, ALICE test and MR test, which we can make out what is the infection, whether there is a staphylococci, streptococci, mycoplasma, and treat the infection. And if the lactobacillus load, normal lactobacillus has got 90% lactobacillus, if it is load is lesser, then we can give lactobacillus corrected and then go in. But I would like to tell you that since 15 years, I am giving lactobacillus to my patients. So I give them prophylactically. So normally, if a patient is coming to me with a couple with failure, I'll give them doxycycline course for 10, 20, 21 days. Many times I give it for 7 days or 21 days. I'll give them a lactobacillus for 2 months. I'll supplement them with various things and then I will do. Stress busting is also very important. Pre-procedural counseling. COVID precautions. Nowadays, COVID is there and it is going to stay for many 2-3 years with us. So education of the patient, teleconsultation, local-based follicle. So instead of calling them for follicle monitoring to you all the way, if it's a large city, they can go to a nearby sonologist and do the follicle monitoring, home delivery of injections, home tests, blood tests, RT-PCR tests for both husband and wife. Before starting, we do RT-PCR tests for COVID. And just before giving the trigger or before starting the progesterone in the FAT, we'll do RT-PCR tests on both husband and wife. If it is positive, we cancel the cycle and we can freeze the embryos and transfer them later on. Breathing exercises, yoga, mindfulness exercises can be done. Acupuncture can be done. Nowadays, a lot of people are doing hand holding. We give them people who can connect with them when they are going through the whole cycle. You can do post-procedural counseling and you can also have infertility support groups. All this will decrease the stress and improve the pregnancy rate. You can also do micronized for poor ovarian reserve. We can give micronized DHEAs, coenzyme Q, transdermal testosterone gel, and melatonin to improve the ovarian reserve 2 months prior to the stimulation. You can enhance sperm quality. You can do DNA fragmentation, and if the fragmentation is more than 30% on tunnel assay, you can give them oral antioxidant therapy for 2 months to the male before going for IVF. You can improve the oocyte quality, which can be predicted based on age, AMH, and previous response. You can do lifestyle modification. If she's obese, you can make her lose weight. Smoking, she can quit smoking, reduce alcohol. I told you Mediterranean diet can be given. Exercise, excessive exercise is not good during IVF. Ovarian supplementation, like as I told you, DHEAs, transdermal testosterone, whey proteins, antioxidants can be given. You can do ovarian rejuvenation by giving intraovarian injection of PRP. We do it in our unit. You can do it translaparoscopically or during the first pickup. Normally these patients, they come, I tell them, poor ovarian results, I say, you'll have to do multiple cycles. So in the first cycle, as we do the pickup, we inject the PRP also to enhance the response in the next cycle. You can do modified ovarian stimulation protocols. We can avoid OC pre-treatment in this patient. Many people are saying that the long protocol gives the best results. Sunkara's paper is there on that. But I normally like to give the antagonist protocol or the mild ovarian stimulation protocol. You can give a dual stimulation protocol as well. We can do multiple cycles, freeze the embryos, pull them together. After that, we can do testing of the embryos for pre-implantation genetic testing, and then we can do the transfer of the embryos. The next is to reduce the complication of hyperstimulation. And the classic long protocol, agonist, let me tell you, I used to do the agonist protocol and it gives the best result. But I always was tensed up. Every month there was a hyperstimulation. So 10 years back, we said, forget it. It doesn't matter even if a pregnancy rate, because even though there are a lot of meta-analysis that show you that the pregnancy rate is the same, whether you give the antagonist or the agonist cycle, in actuality, pregnancy rate is better with the agonist cycle because there's cycle synchronization, more oocytes you get. But it is not worth it. One death in your hand is enough to set you back by 10 years. So last 10, 12 years, I don't remember when I started doing. I've never touched the agonist protocol again. I've gone with the antagonist protocol, and it's a fantastic protocol. And because of this, we can have a OHSS free clinic. That means you can give the antagonist cycle with gonadotropin. Even you can use a combination. Suppose patient is not affording, or patient is a poor responder, or a patient who is a hyper responder. AMH is very high, 9 nanogram, 10 nanograms per ml. In these patients, we can give antagonist cycle, and then we can, if there are more than 15 follicles on the day of the trigger, we can give, if there are less than 15, you give SCG, and you can even do a fresh transfer. If there are more than 15 follicles, you give GnRH agonist as a trigger, and you do the pickup, and you can freeze these embryos and transfer in the next cycle. Even suppose some patients, they insist that, no doctor, even if you are given a GnRH agonist, I want to do the transfer. If you do the transfer in them, you can do the transfer with a high supplementation. Instead of 100 milligrams of progesterone, you give 200 milligrams intramuscularly daily, and you can give 2 milligrams of estradiol validated 3 to 4 times a day. So you supplement high with the luteal support and transfer the embryos. Even if it is a GnRH trigger, you will get about 27 to 30% pregnancy rate. So the pregnancy rate will be lesser. But so this is what is known as a segmentation technology. So you segment, so give an antagonist protocol, give an agonist trigger, freeze all the embryos, and after that you do the transfer in the next cycle. So this is a totally gives a OHSS free clinic. And in order to prevent excessive stimulation, we also, suppose we have a massive ovary, large follicles, many eggs you have got, we will do the trick, give the GnRH trigger to take the oocytes, and then we keep on giving the antagonist twice a day for 3-4 days. Within 4-5 days, the ovary totally regresses down. The next is to strengthen the IVF laboratory. So you need to create more euploid embryos. So you must also prevent the damage to the embryos. So avoid damage to the embryos. So how would you do it? So if you look at this figure, this is the euploid embryo where all these cells, the gray cells are all normal genetically. But if at all there are abnormal red cells, they are less than 30%. So this is called a euploid embryo. On the other hand, if the red cells, that is abnormal genetic cells, are more than 70%, it is called aneuploid embryo. If it has got some cells which are less than 30% red cells, that is abnormal cells, we call it low mosaic. And if there are more than between 50 to 70%, we call them aneuploid high mosaic cells. So it's very important to understand that the aneuploidy in your laboratory, for example, every lab has got different rates of euploid embryos. If you have a fantastic lab, very good lab, some labs have got euploid embryo rate of nearly 50 to 60%. On an average lab will have it about 35-40%. A good medium lab would have it at around 50%, but some labs have got 60% euploid embryos because their lab is very good. So remember, there are two origins to the embryos of aneuploid origin is there. Two types of origin is there. One is a meiotic, maybe normal. So when the fertilization you see here, they are all abnormal cells. Down the road, because of non-disjunction, some normal cells also start becoming produced. And so ultimately the embryo is made up of normal and abnormal cells. As I showed you, based on the number of abnormal cells, it can be euploid or mosaic or an aneuploid cell. So these meiotic divisions are contributed by the parents. Suppose a woman is having younger woman is there, she's taken good amount of supplement, she's taking antioxidants, the stimulation protocol is good, there is no etiology of endometriosis or genital tuberculosis, or AMH is not that low, then she will create good quality eggs. So she will have a better quality embryo. Similarly, in a man, if there is a less age is there, he takes good supplements, antioxidants, and etiology is not infective. In that man also, there will be good quality. So this meiotic contribution will be good to the embryo. But there's another contribution called the somatic origin of aneuploidy. Means after the fertilization, the embryo is normal. There is a normal fertilization of the sperm with the oocyte, but the embryo is normal. But down the road, because of laboratory factors which are acting on the embryo as it is dividing, it starts becoming abnormal. And again, lab with good equipment, quality control, quality assurance, lab monitoring systems are there to monitor the pH and temperature. Embryologists are very skilled. You have got good quality culture media supplemented with antioxidant, good sperm selection techniques, steady temperature. pH is between CO2 you keep between 5 to 6% with a pH which is around 7.2 to 7.4. The oxygen pressure you keep less than 5%. Humidity control is very important. So that osmolality is maintained at 280 to 290 milliosmoles. So the evaporation of the culture media is not there because evaporation can cause damage. Handling systems are there. And so AHU is very important. The air handling system really will improve your pregnancy rate by nearly 20%. Decrease in the particles by VOC and ozone decrease of working. You should run the lights only in the night. Then chemicals and disinfectants should not be used in the lab. You know, the selection techniques in the sperm. So you can do ICSI or you can select the sperm using various techniques like IMSI or so in IMSI you can see that in IMSI we magnify the sperm 6,600 times, and you can select a better quality sperm and then inject it into the. So it's a more advanced technique of that of ICSI. Then there is another technique where you can actually, we can see the spindle here. You can see this spindle. This is called spindle check. So we have got a machine where we can find if there are frozen oocytes and we thaw these oocytes many times due to the cytoskeletal shift. There is a shift of the spindle and nearer when you are injecting it. So you can by seeing the spindle, you can improve the results. So when do you would do a transfer in these patients, or day 2 transfer or a day 3 transfer or a day 5 transfer? So most people are now going for a blastocyst transfer because of the that are there with the blastocyst, where there is an activation of the genome, synchronistalsis, decrease in cervical mucus, increase in endometrial thickness, etc. So blastocyst, remember that if your lab is not good, the embryo will become aneuploidic as it is dividing, undergoing division, and only if you have a fantastic lab, good quality control, then only you should go for blastocyst culture transfers, and as well as in frozen transfers. And now they said that blastocyst is overall better than a day 3 transfer, even in a fresh and frozen. Cumulative pregnancy rate is also nearly same in the blastocyst as well as the cleavage stage. Do laser hatching, by cutting the embryo, by cutting the zona of the embryo, and this is called assisted laser hatching, where normally we can do it. Normally now we are doing it for patients who have failed 2 times before. Repeated IVF failure is a good indication for assisted laser hatching. You can also, this is the Carney's Cochrane review of 2012, which has said that in patients with repeated IVF failure, laser hatching is indicated. The most important aspect of IVF is the embryo transfer. It is a holy grail. The skill of the IVF lab is in the embryo transfer, and it's very important to know when not to transfer. So if there is a poor endometrium with an Applebaum score of less than 16, if there's a very thick endometrium more than 14 millimeters, if patient is having hyperstimulation, if there's an enlarged ovary, the uterus is being pushed by the ovary and you can't maneuver the catheter well, difficulty in maneuvering catheter into the cervical canal, or there's a protocol where you have used clomiphene citrate and the endometrial receptivity is not good. In all these patients, you can freeze the embryos and transfer them in the next cycle. So you can do various protocols for transfer. We can do transfer in a fresh cycle or in a frozen cycle. It can be a programmed frozen cycle or a natural cycle or a modified natural cycle or a stimulated cycle. Many people are now saying that the natural cycle will give better pregnancy rate than a programmed cycle. We like to do programmed cycles in our group, and we don't really find much difference. And it is very important to see that the endometrium is at least more than 8 millimeters in fresh transfers and more than 7 millimeters in a frozen transfer. In my unit, we wait till 9 millimeters, unless it is 9 millimeter. And we also do what is known as Applebaum scoring. So you can see here that we are doing Applebaum. So we look at endometrial thickness. If it is more than 7 or less than 14, it's a good thickness. We look at the echo pattern, laminar, distinct fine-line pattern, myometrial homogeneity, then uterine artery Doppler flow, PI less than equal to 2, uterine artery Doppler flow, end diastolic blood flow should be there, endometrial blood flow, inner zone vascularity should be multifocal, and grayscale myometrial blood flow. All these we give them point scoring, and if it is score is more than 16 to 18, we then transfer the embryo. So you can of course do just 3 things. Look at the pattern, you can look at the thickness, and look at the blood flow. And if it is good, you can transfer it. There's something called compaction also, which can occur where the actually after the starting of the progesterone, there is a decrease in the thickness of the endometrium, and this is called endometrial compaction. And they have shown that if there is a compaction and you transfer, that gives better results. So if there is no compaction, you might as well freeze and transfer in the next cycle. You can also do an ERA test, which we don't do in our practice. See, endometrium can be analyzed by various things. You can biochemically analyze it. So if a progesterone level if you're doing a fresh transfer, if progesterone level is more than 1.5, you don't transfer. That's a biochemical way of analyzing the endometrium. You can biophysically analyze the endometrium by doing an ultrasound and use a Applebaum score to biophysically, which we do. And you can do a molecular analysis of the endometrium by doing a receptor analysis test, which is called the ERA test. So which we don't do. So, different people have different things. How many embryos do you transfer? So this is a Pandian's paper where he has said that there are 14 RCTs, and 2 embryo transfer and 3 embryo transfer doesn't give difference in pregnancy rate. But 1 embryo transfer and 2 embryo transfer, if you compare, naturally the double embryo transfer will give better pregnancy rate, but the multiple pregnancy rate will be higher. So what they have advocated is you can do 1 plus 1 frozen. So 1 fresh plus 1 frozen. Or if you are going for a freeze-all unit, you can do 1 freeze-all transfer. If that fails, another freeze-all. That is why the SART registry has now changed the definition of the pregnancy rate. So what they have said, from 1 oocyte retrieval, if you get enough embryos and you transfer them whenever you want in the next 1 year, the pregnancy rate will be calculated of the combined transfer. So that is why now we are going for the SAR, this thing. Single embryo transfer also improves the perinatal outcome. The single embryo transfer gives better perinatal, lesser complications are there as compared to a double transfer. So what is the ASRM guideline for transfer? This is a lovely guideline. So if you have got a system where you can analyze the embryo genetically, it is called euploid embryo. So if you have a system where, so if there's a patient who is less than 35 years, you do single embryo transfer regardless of the stage of the embryo. Whether it is a day 3 embryo, day 5, single transfer you do to start with. If that fails, then next cycle you can do 2 transfers. That's a different story. But first cycle, if you identify a very good, even a day 2 or a day 3 or a day 5, they'll give a good pregnancy rate. Between 35 to 37 years, again, you can do a single transfer. Between 38 to 40 years, you can do more than 3 cleavage stage embryos or 2 blastocysts. In case of euploid transfer, a single blastocyst transfer. So remember, if you have a testing facility where you can test for euploid, then a single euploid blastocyst you transfer irrespective of the age of the patient. However, if you don't have the testing facility for genetics, then this is the advocated transfer. So you can also do a sequential transfer. So in my group, we get a lot of patients from all over the world who have failed many times. So we freeze the embryos, and on day 3, and when we thaw them on day 3, we put 1 embryo, remaining we culture to day 5, and in day 5 we put 1 blastocyst. We can do that, and that gives us very good pregnancy rates. In our group, we have fantastic pregnancy rate because of this day 3, and the variability in the endometrial maturation process and increasing of the receptivity window is the main reason for performing sequential transfer in our group. So what are some of the important things that you should know about in embryo transfer? One is that day 3 transfer better than day 2, except in poor responders. Day 5 transfer of blastocyst culture will give definitely better results. Removal of cervical mucus is very important. Mid-cavity transfer. So transfer 1.5 centimeters below the fundus, or between 1 to 2 centimeters below the fundus is a good type. And you should use a coaxial soft catheter, which will give you very good pregnancy rates. And this is a ASRM survey which was done to find out what are the transfer techniques in amongst the physicians. So trial transfer is done in 40%. Clinicians do trial transfer followed immediately by embryo transfer. Many 30% do afterload transfer, 27% do direct transfer, and many of them 66% discharge embryo in the upper cavity and 29% discharge embryos in the lower cavity, mid cavity. So of course, I am a person who does straight. I do no trial and all. I load the embryos and transfer them, bang them right into the. And we have found that the best chance is if with the 40 to 50 seconds from the loading of the catheter till the putting it back. If it is in around 40-50 seconds, 30 to 50 seconds gives the best result. You should not exceed more than 120 seconds. If there is some difficulty and you can't transfer within 120 seconds, that is 2 minutes, you put back the embryos into the incubator, freeze them, and you cancel the cycle, and you call her for a hysteroscopy, dilatation, see the cavity, dilate it, look at the cavity, do resection if you need. Sometimes the cervix is jutting it, you do some resection, and then do the transfer in subsequent cycle. Do you need to do bed rest? There are a lot of studies that have shown that bed rest, in fact, will reduce the pregnancy rate. Many units, they immediately transfer and take the patient out, but some patient, in our unit, we keep them for 10 minutes because otherwise patient, if they don't become pregnant, will say, oh, doctor didn't keep us on the table. He put the embryos and he immediately removed us. So because of the patient getting hassled, we keep them for 10 minutes on the table. You can also give adjuvants like pyroxicam, or we give pyroxicam to reduce the contractions after the uterus. You can give atosiban also for this patient. So you can also cryopreserve the embryos, especially if the, as I told you, if endometrium is not receptive, or patient is hyperstimulating, etc., etc., you can cryopreserve the embryos. And there are different techniques, slow versus vitrification, and there's no doubt that vitrification gives the best result. And there has been a meta-analysis comparing fresh versus frozen transfers, and the fresh was associated with lower risk of placenta previa, placental abrasion, and low birth weight compared with, so FET was associated with lower risk. So frozen transfers had lower risk of placenta previa, placental abrasion, low birth weight. But frozen transfers were also associated with increased risk of PIH, postpartum hemorrhage, large for gestation. So don't think that transfer, your pregnancy rate is good, so I should do freeze all. There are downsides to the transfer as well. Should we freeze all and transfer? So Dr. Shapiro was the one who said better to freeze everything and transfer in the next cycle. But there are a lot of studies that have shown that there are advantages or disadvantages. I personally feel that if you can, you should transfer at least, suppose there are 4 embryos, I would transfer at least 1 embryo in that cycle. If it is, she is not hyperstimulated, lining is good, blood flow is good, progesterone level on day of trigger is less than 1.5, etc., etc., I would take my chances, because every patient likes to become pregnant in the same cycle. Why she should delay? In fact, the delay, by freezing, you're delaying the time taken to transfer. Reducing multiple pregnancy rate is very important also. But can you reduce the multiple pregnancy rate without compromising? Can we put 1 embryo and get the same pregnancy rate? So I told you that American Society has said that if you have genetic testing facility, you can put a single blastocyst for all ages of patient and you will get the same result. So there are different ways of selecting embryos and all, morphology, etc. So the commonest is this is a time-lapse technology which is there. So you can see this is the embryoscope which we bought. We were the first in the Asia. Even before Japan, I got this embryoscope in 2012. We installed it in our lab in Lilavati Hospital in Mumbai. And in this, we do these are 20 microliter droplets which are there. And this is the RCT that is been shown by Armstrong that there's no difference in live birth rate whether you do time lapse or not. But personally, I feel that the incubator is so fantastic. Every 6 months they come and change all the parts in the incubator. Imagine every 6 months they change the parts. So naturally, and it is a 5-5-90 mixture. You don't open the incubator. You have got micro droplet culture. All these things, it gives a better quality embryo. Forget the identification of good quality embryo. Inherently, it yields, but it's very costly. I hope that someday the company can make the embryo at it is nearly the cost is nearly $100,000 for one time-lapse machine. So in that you can actually buy 10 normal incubators. So so here you do the ICSI and then put them in the droplets, and then you cover it with oil and then put it into the incubator, and then they will take photographs of the. Now what they have done, this D. Tran et al. In Australia, they have studied 1,15,000 embryos, and they have created an artificial deep learning analysis system called the IDA scoring. And so by using the score, they can make out and they can predict, okay, if there are 5 embryos who have become blastocysts, this is the embryo which will give you the best result if you put it in. But it's a very costly, all these things. Not every one of us can afford it. So you can see here the machine takes photograph every 15 minutes, and after the blastocyst is formed, you can play the video of each embryo, how it has evolved in the incubator, and based on that you can predict. And using the IDA score, now the new artificial intelligence score, you can predict which is the best embryo for transfer. But a simpler system has been produced called ERICA, Embryo Ranking Intelligent Classification Algorithm, which we also have got. It is from Mexico, and Dr. Badiola is the man who has invented ERICA, where we can just take the blastocyst. When the blastocyst is formed, we take the photo of the blastocyst and we export it to ERICA through the server, and as soon as we export it, within 2 minutes, ERICA gives the report. So they give report based on color. So if it is green color report, then that means that if there are 4 embryos, you export them, they'll grade the embryos, and you can say, oh, this is the embryo. If I put, I'll get the best chance. So you can start with the best embryo to give the better chance. You can also do a traditional biopsy of the embryo, which is known as pre-implantation genetic testing. And this is also a system. We have an in-house, the latest analysis of the embryo is by the NGS system, which we have in our group. One of the few groups who has in-house NGS system in the world. So what we do is we can take actually the NGS, you can see here. So we can do the biopsy of the system. It's not playing, unfortunately. This is not playing. So I would have shown you that. I'll show you later on. So we do a biopsy of the system. And then we amplify the DNA. Once the DNA is amplified, we then do template generation, and then the sequencer reads the sequence, and we can tell you whether this is a genetically abnormal embryo or not. And this is a study by Dr. Santiago Mune, where it's a start where he showed that in women more than 35 years of age, the PGTA analysis really works a lot. Less than 35, it doesn't have that much of this thing. There is also a new technology. So instead of biopsying the embryo, there's a DNA that leaks around the embryo, and you can analyze the DNA. This is also a new technology which we have brought, and for the first time in India. And with this also, we have started getting a lot of patients who have failed. We can now do analysis of this patient using non-invasive pitches. So without biopsy, so we don't have to bother with the tech, the skill of the embryologist. You can do it without. And now the new breakthrough has come is that where you can do this technique for even single gene defect. It's the latest technique that has come in, which we will start in our unit as well. So we can also do genetic analysis. I told you we can do an ERA test. We can do ALICE to see whether there is a microbiota problem or not. If there's a thin endometrium, we can put GCSF inside the endometrium to grow the endometrium, or we can do PRP also, or you can do endometrial reconstruction with stem cells. You can use bone marrow stem cells from the iliac crest, and some of the groups in our India are doing the bone marrow. It is just being allowed by the government. So if there is autologous cells, if you take the stem cells and you don't modify the stem cells and re-inject them back into the patient, that has been allowed. You can also do surrogacy or transplant. If the uterus is badly damaged, especially in the African continent, too much damage is there. Adenomyosis, multiple fibroids. In our India, there is a huge amount of tuberculosis damage, total destruction of so in those patients, you can do uterine transplant. And the new technology in transplant is the cadaveric transplant. It's a very great technology. So first it was a live, but live is always a threat to the donor. But now cadaveric transplant has taken place, and a lot of patients are becoming pregnant. You have to also look at patients, I get 6, 8 failures, 10 failures, 12 failures, 14 IVF failures. So overcoming failures is very important. So in patients of failures, I would do a 3D ultrasound, hysteroscopy. You may do endometrial receptivity assay. You do immunological profile. We will do genetic profile of the parents, and we should also look for tuberculosis and other things like here. And you can also do sperm selection. So in the embryo, you can do sperm selection using, if there is a recurrent ICSI failure, you can do non-invasive PGT or PGT to analyze the embryo, or you can use a ERICA or embryo score or with IDA to select a good quality embryo. You can combine these two techniques. Then we can retrieve and transfer in the next frozen. Frozen cycle always gives better result. When you are transferring, you can do sequential transfer and you can do assisted hatching. So all these things we do and give better result. If there is a thrombophilia patient, you can give them aspirin and heparin combination. And if there is a mother, you can treat the pathology. You can identify the implantation window with ERA test. You can stimulate the endometrium with people. Endometrial scratch is a big controversial thing, but there are a lot of studies that are showing that endometrial scratch really works. You can use GCSF PRP. We use a lot of GCSF PRP in repeated IVF failure. So we will put the PRP on the day of starting the progesterone, and then 2, 3 days, 5 days later, we can do the transfer. We also use adjuvants like aspirin, heparin, steroid, intralipid, and we can also do lid therapy. So these are the various adjuvants we use, especially if there's an autoimmune disorder, heparin, aspirin, intralipid, steroid. We can use adalimumab, but you have to be careful to see that you don't have tuberculosis. You can do IVIG, or you can do lid therapy as well. Intralipids is commonly used by us in our group, and it is a 20% fat emulsion of soybean oil, egg yolk, and phospholipid and glycerin. And what we do is we give it it's very thick and viscid. So you have to take 4 ml, dilute it in 250 ml of saline, and you have to give it every 3 weeks. And this has given very good outcome. Of course, if everything else fails, you can always go for egg donation or surrogacy if it is allowed in your country. Also, it's very important to give birth to genetically and epigenetically normal children. So in the future, almost everyone will be tested. So all the embryos will be genetically tested. As I told you, non-invasive testing is becoming better and better. And once that becomes very accurate, or we have got new breakthrough, Dr. Santiago Mine, who actually was a proponent of pre-implantation genetic testing. He's also now coming out with metabolomics, analysis of pyruvate levels, oxygen levels in the culture media around the embryo. And based on metabolomics technology, we can predict the viability markers in the embryo. So this will be coming in the future. And it's lastly, IVF should be made cost effective without affecting outcomes. See, I mean, I believe that it's not fair for us to say, because the patient is poor, we give them technology. And, many of the people, I don't want to mention them, but suppose in Africa, why should you give them substandard technology? The technology should be the same, whether he's a rich patient or poor patient. You don't charge money for it. That is how you have to do it. You can't give them vaginal culture and do this thing and that thing and mild stimulation. Will you do it for your own brother, mother, sister, wife? No, no. Then do things for the patient which you will do for your own relative. Don't modify the thing. This is my philosophy. So our group has Bloom IVF has been there for last 25 years. We have very high pregnancy rate. We have a lot of egg freezing facilities. We are masters in treating recurrent failures and recurrent pregnancy losses. Now, I told you we have in-house NGS now, and I'm very excited. Yesterday I was just listening to the master from China, where I was trained in non-invasive PGT, and he has now come out with a linkage analysis and PGTM, the single gene effect, again non-invasive. So I'm so excited. Yesterday I was listening to him at 1 o'clock in the night. So what is the future? Future is a single embryo transfer using euploid blastocyst. Euploid means genetically normal blastocyst. You freeze it. You use the analysis of PGS, non-invasive, and you can use also artificial intelligence using ERICA. You can combine the two techniques. You can decrease the time to pregnancy. You can have high success with single pregnancy, with low miscarriage rate, with low imprinting disorder. See, there are two types of disorders. One is a genetic disorder and one is a methylation disorder. That is called an imprinting disorder. And imprinting disorders are also quite common in our unit, in our IVF field. And so we have to be careful. You can't just use any chemical. Tomorrow you will say, Acha, I have got this plastic. Why should I use some tested thing? I will use a non-tested thing. But you don't know what will happen to the child 40 years down the line. He may have higher incidence of cancer. So you cannot use any material you want. You may get the pregnancy, but getting the pregnancy is not enough. Getting a pregnancy with a no incidence of, or a low incidence of abnormality and a low incidence of mutagenicity, a low incidence of cancer in the future, that is what we have to aim for. Finally, the last road, my master's was in Eastern Virginia Medical School under the great Howard Jones. He died at the age of 100 or 102, and he was my boss. And he gave a lecture, and he said there are 7 roads, and the last road was, he said, the 7th road has not recently been trodden. Aldous Huxley in Brave New World, published in 1932, described IVF as a science fiction. IVF has now been accomplished. He also described what he called exogenesis, namely the development of the conceptus in vitro to the point of viability. Means total development of conceptus in the lab from embryo till 9 months. And that is what will be the future. The future of IVF will be based on that. And I hope that, my children or whatever will be able to do that exogenesis. Of course, IVF, the Nobel Prize, Dr. Edwards got in 2010. And this is my Dr. Rishma, my colleague and business partner, Dr. Nandita. This is Dr. Edwards. And this is the great Dr. Yuri Verlansky. He's got the biggest genetics institute in the world in Chicago. And that's me, yours truly, looking quite young. And this is my team, of Dr. Sudesh Kamath, my embryologist, who has been there since 1994. Me and Dr. Khanwala is now in Africa, and Dr. Nandita, who is my business partner. And these are some of our babies. Thank you for a patient hearing. It went a little bit ahead of time, but I hope you will excuse me and forgive me for that. Thank you.
Thank you so much, sir.
Thank you, Ritu.
Thank you so much, sir. Vaibhav, can you take some questions if are coming from online? Here, so I'm seeing all the only appreciations. A lot of appreciations are coming. So, sir, I think there are no questions today.
Okay, great.
Very nice. So thank you so much, sir. Thank you.
Great. Thank you.
Yeah.
Thank you.
Yeah. With this, we will wind up today, friends. So good night. Happy Diwali to all of you in advance. So a lot of doctors are writing the appreciation.
Yeah. Thank you.
Okay, sir. Okay. So friends, do log in tomorrow at 9:30 p.m. Tomorrow we are having Dr. Nandita Palshetkar madam with us with a very interesting topic, the mystery